Okay. Right.
Is that my present? Can you see my presentation?
I can.
Great, thank you.
Got one other quick question to ask. When I start to admit people, can you see that or can you not see that?
So when I'm screen sharing,
Yeah.
I can't see. I've got you in a tiny box at the bottom, but I can't see the other people.
Fine.
Yeah.
Right. I think oh God, I've got more people. Just gonna let some more people in. Right, I don't want to take me off.
I'm getting some.
Okay.
Friday. I'm getting there.
Catherine, do you want to start now?
Yeah.
Okay. Good afternoon, everybody. Welcome. Thank you for joining. I'm Deanne. You know who I am. I'm your Assistant Primary Care Liaison Manager. And today we have Dr. Catherine Cox, who is one of our consultants for haematology. We'll be giving you a talk on haematology and abnormal bloods and so forth. And also, can I just remind you, if you can switch off your screens and if you can switch off your microphones. And also just to note that this session is being recorded. Over to you, Catherine.
Okay, great. Thank you, Deanne, for that introduction. And thank you for inviting me here today to talk to you about common conundrums in primary care haematology. So I'm Catherine Cox. I'm actually one of the haematology registrars, but I'm in my penultimate year of training. And over that time, through telephone... Oh, hello?
Hello. Still
Can
got
you hear?
you.
Okay, yeah. I'm just getting some echo. And over that time, I've come to know through telephone consultations and through online advice and guidance the sort of problems that crop up in primary care regarding full blood counts and haematological conditions. So I thought I'd want to talk to you a bit more about those today. So as a background to this presentation, I looked through Kinesis. So Kinesis, as probably most of you are aware, are our online portal where you can connect to secondary care specialists for advice and guidance. And this can be on new problems or on existing patients that are being managed in the community. And the reason why Kinesis and such portals are really important is we've got a growing number of patients with haematological diagnoses that are being managed both in primary and secondary care. And this is because we've got an ageing population. we've got more complex treatments and patients are living longer. So hematological presentations that 10 years ago may have been life-limiting are now thought about as chronic conditions. And the emphasis is managing these patients as much as possible locally in the community. So what Kinesis helps us with, it helps us to risk stratify. So there are some patients who we're able to support in the community, some patients who need some connection with secondary care, and this could just be through advice and guidance or telephone calls. And then we need to highlight those patients that need to be referred to us for further investigation and management. So I looked at the past 100 referrals that were sent to one consultant during their on-call periods, and this was spread out throughout the year from November 2019 to November 2020, and picked out the main topic from each question asked. And the pie chart on the right here reflects the topics that we saw. So in fact, a quarter of the queries were about macrocytosis, and as a basis of this, I'll spend most of the time during this talk talking about macrocytosis and its causes. The second most common cause was hematinic deficiency, which we'll go into in a bit more detail, and cytopenias. Ferritin and thrombosis followed next, and then there are a handful of queries about other hematological conditions. So just to sort of clarify, the aim of this presentation today is to really go over these three topics highlighted. So macrocytosis, hematinic deficiency, and cytopenias. So macrocytosis, it's a very common conundrum. So a study done back in 1991, so quite an old study now, of 300 consecutive adult health centre patients showed that the incidence of macrocytosis, a mean cell volume above 100, was in fact 2.4%. So it's pretty common. So I just have a question to start off with. Is what do you think is the most common cause of macrocytosis with or without anemia? Now, either you can pop your answers in the message box or just have a think to yourself. But we have A, alcohol, B, hematinic deficiency, C, primary hematological disorder, or D, drugs.
One alcohol.
So, to answer this question,
four alcohol opinions at the moment.
I think we've got a lot of answers for alcohol coming through on the text chat. Now, there was a study done in 2009, and it compared a population in New York of adults aged 18 plus and a population in Finland aged 18 plus, and it looked at the causes of macrocytosis on full blood counts that were done through their primary care settings. And in fact, yes, so 33% of macrocytoses that were found in these outpatient full blood counts were due to alcohol. And when they looked at this in a bit more detail, in fact, a subset of patients that were under 75, alcohol accounted for 65% of macrocytoses. And this is due to a number of reasons. Alcohol has a direct toxicity on the marrow. It's associated with nutritional deficiencies and also liver disease. The second most common cause was hematinic deficiency. So we'll speak about this in a bit more detail, and we'll touch on medications. However, at this point, I also just wanted to highlight this group here. So 5% of macrocytoses were secondary to hypothyroidism. And there's been studies that shown that up to 55% of patients with hypothyroidism will at some point develop a macrocytosis. And this is due to insufficiency of the thyroid hormones themselves, as they have a direct effect on hematopoiesis without any nutritional deficit. So hematinic deficiencies. It's the second most common cause, and by this we mean B12 and folate deficiency. So there was a large survey done of US and UK patients, and it found that over 6% of those aged 60 and above are B12 deficient, and the prevalence only increases with age. However, if we think about the population under 60, on this study, what do you think was the most common cause of hematinic deficiency in adults under 60 in the UK and the US? Was it A, medications, B, malabsorption, C, dietary deficiency, or D, pregnancy? So the answer was in fact dietary deficiency, and evaluation of diet, as we can see in the middle here, is one of the key topics that this is a table taken from the British Society of Haematology guideline on B12 and folate deficiency. And they have a number of key topics to think and have in the back of your mind, could this patient be B12 or folate deficient if they come to you? So at the top of the list, as we know, any anemias, always think, is there a B12 or folate deficiency? Glossitis is a very common presentation of low B12, and similarly, mouth ulcers may reflect a folate deficiency. Patients presenting with neurological symptoms, I know the differential is wide, including diabetes and carpal tunnel. However, we should always remember to check B12 levels. And if patients already have a malabsorptive condition, if they have steatohorrhea due to pancreatic disease or celiac disease or Crohn's, we should think about keeping an eye on their B12 and folate levels. Patients with autoimmune diseases, we know that a positive family or personal history increases their pre-test probability of pernicious anemia. And there are a number of medications that are used in primary care that can cause B12 and folate deficiency. PPIs, by increasing gastric pH, lead to a reduced absorption of B12. Metformin, as it can cause malabsorption in the bowel, can influence our B12. And the oral contraceptive pill is also associated with low levels of B12. Pregnancy. We know that pre-pregnancy folate supplements are important to reduce the risk of neural tube defects. And low B12 levels are found in the third trimester and are felt to be partly physiological. And cognitive impairments. Now, this is one of the things I wanted to highlight. So low B12 levels of uncertain significance in the elderly can be associated with cognitive impairment. So if you've got someone with low B12, always ask about any new memory problems. Conversely, if someone's coming to you with new memory problems, always think to check their B12. So I just have a question for us to work through. So there's a 64-year-old man who presents with a history of bilateral leg paresthesia. He has no previous past medical history. He's on no regular medications. He is vegetarian and teetotal. He has no GI symptoms suggesting malabsorption. He's got no symptoms of peripheral vascular disease. We've looked at his blood tests. His hemoglobin is normal. His MCV is a little bit raised. His white cell count and platelet count are normal. His folate is good, 8.9. His ferritin's okay, and his B12 is also within our normal ranges. There's no evidence of diabetes on his HbA1c, and his myeloma screen is negative. So just think to yourself what you would do with this patient. Would you A, start some B12 supplementation for him? B, send further investigations, but keep B12 deficiency in the differential? C, send further investigations, but you're happy that you've ruled out B12 deficiency? Or reassure the patient that all his blood tests are relatively normal and leave it there? So one of the things I really wanted to highlight about B12 deficiency, it's most of the time not the classical megaloblastic anemia that we think of. So neurological presentations, peripheral neuropathy, may occur in the absence of any hematological changes, but early treatment is essential to avoid permanent neurological disability. Low B12 levels of uncertain significance may occur with non-specific symptoms and no anemia. And patients with the strong clinical features of B12 deficiency may, in fact, have a serum B12 level that lies in the normal reference range, a false normal B12 level. And the patients I particularly wanted to highlight here were those with very high intrinsic factor antibodies, as high intrinsic factor antibodies can actually cause a false normal B12 level. So this is a bit of background about B12. So our majority of our B12 is from our food protein. When we ingest it, our salivary glands produce an R binder. This travels with the B12 into the stomach. In the stomach, gastric parietal cells produce pepsin. This cleaves proteins off the B12 and allows the R binder to join with the B12 and protects it from gastric acid. The gastric parietal cells also produce intrinsic factor. These two then move into the small bowel, and it's here that proteases split the R binder from the B12, allowing it to bind to intrinsic factor. And intrinsic factor takes it then down into the ileum, where it binds with intrinsic factor receptors, and the B12 is able to be absorbed into the bloodstream. And why is B12 so important? So it plays a critical role in the pathways for DNA synthesis by converting homocysteine to methionine. So you have a patient that you're concerned might have a B12 deficiency. How best should we investigate them? So we should always do a full blood count, but as we've seen, it may not always be helpful. So the hemoglobin may be normal or it could be low. The MCV may be normal or high. A blood film can be helpful. It can not only confirm the macrocytosis, but show us other features, such as here on the little blood film, the top neutrophil is hypersegmented. And we're able to measure serum B12 levels. Now, this test is widely available and is very cheap, but it lacks sensitivity and specificity. So there are other tests available that can help us work out the diagnosis. So if we go back to our pathway, we can see that if we have a lack of B12, there will be a build-up of homocysteine and methylmalonic acid, as this pathway cannot continue. So we can measure these levels. Plasma methylmalonic acid increases in B12 deficiency, and plasma total homocysteine increases in B12 deficiency. And this often rises early in deficiency, so it can be a useful early marker. Now, holotranscobalamin assays are also available. They're an immunoassay for the active fraction of B12. They're very sensitive and specific, but not widely available. And at this point, I also wanted to talk about testing for intrinsic factor antibodies. So pernicious anemia accounts for 20 to 50% of vitamin B12 deficiency in adults and is associated with an autoimmune gastritis, resulting in the destruction of gastric parietal cells and the associated lack of intrinsic factor. So we can measure intrinsic factor antibodies. This is a chemiluminescent assay, and it has a 95% positive predictive value for pernicious anemia. However, it is only present in 40 to 60% of pernicious anemia cases, and you can get false positives if the patient has recently had B12 injections. Gastric parietal cell antibodies are also available for testing. They are positive in 80% of pernicious anemia cases, but are also present in 10% of the normal population, so it's not recommended as a screening test. So, coming back to our patient, the 64-year-old man with paresthesia in his legs. What are we going to do next with him? So this table is taken from the BSH 2013 guideline on B12 and folate deficiency management. And we can see that our patient definitely fits into this category highlighted, that we've got a strong suspicion that they might have a B12 deficiency because of their paresthesia. However, his B12 levels were within the normal reference range, so he fits into this category here. Now, it is recommended that we check his intrinsic factor antibodies and check a second-line test to try and confirm our diagnosis, but to start empirical B12 supplementation for him while we're waiting for these second-line tests. So our patient was negative for intrinsic factor antibodies, but had a raised MMA. And on the basis of this, we can confirm his B12 deficiency and start him on appropriate treatment for it. And this is a table of treatments. So patients without neurological symptoms, is mostly aware, should have 1 milligram intramuscularly 3 times a week for 2 weeks, and then a booster every 3 months. Our patient, as he has paresthesia, should have 1 milligram intramuscularly on alternate days until symptoms start improving, and this should be for a minimum of 3 weeks, and then a booster every 2 months after. Patients with subclinical deficiency can be managed with low-dose oral medication. And if you want to assess whether the B12 is working, a full blood count taken 7 to 10 days after supplementation is started should show a raised reticulocyte count in response. If it doesn't, we may want to consider our diagnoses. And common side effects can include transient hypokalemia, itch, rash, fever, nausea, dizziness, and anaphylaxis. However, as 2020 has thrown us a lot of new things, the BSH have also produced some new guidance for us on how to manage B12 replacement during the COVID-19 pandemic. And this is their suggestions. So for non-dietary causes of B12 deficiency, continuation of intramuscular supplementation should be discussed with all patients. As an alternative, oral cyanocobalamin can be offered at the dose of 1 milligram a day until regular IM injections can be resumed. However, patients, if they're already self-administrating, then do carry on. And it's suggested that all B12 deficiency secondary to diet should be offered an alternative of oral replacement given between meals. So that concludes our section on low B12 deficiency, and I just wanted to throw in here a quick slide about raised B12, because I know that it's often a cause of concern with an unexplained raised B12 of could there be an underlying hematological cancer. And this also cropped up as one of the Kinesis queries. So yes, raised B12 can be associated with hematological malignancy, and therefore if it's unexplained, we would always recommend that you check a full blood count, myeloma screen, and blood film. However, it can also be associated with other conditions, and this includes excess intake, and particularly to highlight, this can be multivitamins that are over the counter. Renal failure can be associated with raised B12, as can liver disease, as we store some liver in the B12, and it's released when there's damage. And solid tumours are associated with raised B12, along with hematological malignancies. And inflammatory disease can cause it as well, so always consider checking an ESR, CRP, or autoimmune screen. So coming on to the other side of hematinic deficiency is folate deficiency. So folate, as we all know, is the term that we use encompassing all the different biologically active forms of the vitamin, whereas folic acid is a synthetic form that we use in supplements, fortified foods, and treatments. Both types are absorbed from the proximal small intestine, and almost half of the body folate is found in the liver. The bioavailability of dietary folate is influenced by many factors within the intestinal lumen, and natural folates in food are vulnerable to degradation during the cooking process. But folate deficiency is commonly associated with poor diet, high alcohol intake, GI disease, conditions where there's increased red cell destruction. This could be something where there's chronic hemolysis, such as sickle or thalassemia, exfoliative skin disorders, pregnancy, and rare conditions such as MTHFR gene mutations. One fact that I learnt putting this talk together, and again to highlight the importance of dietary evaluation, is that goat's milk has a much lower folate content than cow's milk, so it's something to ask about when you're taking a dietary history. And when we talk about high alcohol levels, studies have shown that an intake of over 80 grams of ethanol a day, so this is the equivalent of 8 small glasses of wine, increases the risk of deficiency. And again, as we've already mentioned, in pregnancy, folate requirements increase, and folate is preferentially delivered to the fetus. And here on the right, I won't go into this in detail, but we can see where folate and folic acid filters into the pathway further down from B12, but along the DNA synthesis pathway. So for testing, we have a serum folate chemiluminescence test. And in fact, there's actually still no general consensus about normal ranges, but in general, under 7 nanomoles or 3 milligrams per litre is used as deficiency, and there is an indeterminate zone between 7 to 8 nanomoles per litre or 3 to 4.5 micrograms per litre. We can measure red cell folate. This is an estimate of tissue folate status over the time of the red cell, but there's a great number of pre-analytical and analytical variables. And again, we can measure homocysteine. This will also increase in folate deficiency as it does with B12. And we can also see a rise in this in B6 deficiency, renal disease, or hypothyroidism. There is a possibility of false positive folate tests if the patient has recently had oral folate intake, and false negative tests can present in patients with anorexia, acute alcohol intake rather than chronic, pregnancy, and anticonvulsant therapies. Treatments, it's generally recommended that patients have 5 milligrams daily for 4 months. However, if the cause is secondary to malabsorption, they should have 15 milligrams a day. Prophylaxis in pregnancy is 200 to 500 micrograms, and prophylaxis for hemolysis or chronic dialysis is 5 milligrams a day. So that concludes our section on hematinic deficiency, and I wanted to briefly discuss common medications that lead to macrocytosis. And again, the study comparing populations in New York and Finland found that of medications that cause macrocytosis, 15% were caused by antiviral medications. And these are things like reverse transcriptase inhibitors, zidovudine that we use for treatment of HIV, and lamivudine for hepatitis B. Anticonvulsants, phenytoin and sodium valproate are known to cause macrocytosis. Folate antagonists such as methotrexate, and patients on chemotherapy, particularly alkylating agents and purine inhibitors. Trimethoprim and the family of antibiotics are known to cause a macrocytosis. And probably one of the most commonly used medications in primary care, metformin, can lead to a macrocytosis. And again, this is most likely secondary to malabsorption it can cause in the bowel and low B12 absorption. Now, the next category in the study they labelled as miscellaneous, and these are mainly sort of artifactual causes of macrocytosis. Pregnancy we've spoken about, but COPD isn't often thought about when we think about macrocytosis, but it can lead to it, and hypoxia triggers erythropoietin excretion and subsequent massive erythrocytosis. Patients with hypoglycemia, there's osmotic disequilibrium between the erythrocyte and the dilutant used in the automatic red cell counter, leading to an artifactual macrocytosis. And again, patients with raised white cell counts, the increased turbidity of the sample in marked leukocytosis can cause the machine to overestimate cell size. When cells are in storage, they swell. So cells that are left in transit or inappropriately stored can become macrocytic. And patients with cold agglutinins, when the red cells agglutinate, it affects red cell measurement, leading to a spurious macrocytosis. And there are some congenital syndromes that are linked to macrocytosis. It is very common in infants with Down syndrome, and in some studies macrocytosis is found to persist throughout life in 2/3 of individuals with Down syndrome. And then we come on to our hematological causes. So actually only 5% of macrocytosis is found to be from a primary hematological cause. And these we can really split into 3 categories. Firstly, reticulocytosis. So reticulocytes are larger than fully mature red cells and therefore trigger this macrocytosis when registered on an automated FBC. And these can be found in if there's been bleeding and the recovery, so the bone marrow is making lots of red cells, or conditions where there's chronic hemolysis. Again, hereditary spherocytosis, hemoglobinopathies, or G6PD deficiency. I think the thing that we always have in the back of our minds and that worries us is, could this be a presentation of MDS or an acute leukemia? The thing that's very helpful here can be a blood film. So in this photo, we have a macrocytic blood film, but we can see two neutrophils in the centre. Now these are hypogranular and hypolobated and appear quite dysplastic. So this blood film and a macrocytosis without any other cause would raise suspicions of MDS. And myeloma. Myeloma, through its infiltration in the bone marrow, can lead to a macrocytosis. So always review whether the patient has anemia, hypercalcemia, or renal impairment with their macrocytosis. However, in the main study, the third most common cause, as we can see here highlighted in the lime green, that should actually say unestablished. So what do we do with these patients when the cause is unestablished? So this is a quick summary. It shows the tests that we've talked about. So if there's a B12 or folate deficiency, please replace and establish the cause. If there is a history of increased alcohol intake, liver disease, thyroid disease, it may require specialist input from other specialties. But anyone with a reticulocytosis, a new paraprotein, or here we have our persistent and unexplained macrocytoses, please refer to us in haematology. So I think we're going to have time for questions and answers at the end. So I'll just move on to our second topic, which is immunoglobulins. So this was 15% of the Kinesis questions, and I think it's often felt as a bit of a complicated and daunting subject. So I just wanted you to consider this question to begin with, which we will find the answer to as we work through. So what percentage of patients that are found to have a new paraprotein have myeloma? The answer A, 5%, B, 19%, 39%, or D, 65%. So whilst you think about that, a little bit of background about immunoglobulins. So there are antibodies. They're made out of two sections. The first is our light chains, which are these green short blocks, and they can be of kappa or lambda varieties. The second is our heavy chains, and this chain is what we use to then describe the immunoglobulin as a whole. So our IgA is our immune function for our mucous membranes, IgG our secondary responses, IgM our primary. IgD is a B cell receptor, and IgE, as we know, is involved in allergy and parasitic infection. So when we look at immunoglobulins like this, it can look a bit complicated, but I wanted to break it down into two main sections. So you've done a blood test for a patient and you've found that their immunoglobulin levels are decreased. Now, in rare conditions, this can be due to a hereditary cause, such as IgA deficiency. However, the majority of decreased immunoglobulins are acquired, and this can be secondary to nephrotic syndrome, immunosuppression, whether it be from a chronic infection or medications, and also B-cell malignancy. So if patients have low immunoglobulins, think, have they had any B symptoms, lymphadenopathy, splenomegaly, and with the screen, do they have a paraprotein, which we'll come on to. If we think of the other side of the diagram, so you've done their immunoglobulin screen and there's an increased immunoglobulin, the first question to ask yourself is it polyclonal or monoclonal? So a monoclonal immunoglobulin, called an M protein, also known as a paraprotein, is an immunoglobulin produced by an expansion of clonal plasma cells. And this can be a whole immunoglobulin, such as an IgA paraprotein, IgG paraprotein, or an abnormal light chain production. And it's these proteins that we associate with our hematological malignancies and their precursors. So MGUS, amyloid, and myeloma, Waldenstrom's, and other LPDs. Now, if you've got a raised immunoglobulin, but it's polyclonal, it's unlikely to be related to a hematological condition, but most likely reactive. And this can be seen in liver disease, solid malignancies, autoimmune and inflammatory conditions, and chronic infections. So you found a patient with a new M protein. First of all, I wanted to talk about MGUS, so monoclonal gammopathy of unknown significance. What is it? So it's a pre-malignant monoclonal plasma cell disorder. Myeloma is always preceded by MGUS, and MGUS is very common. At the age of over 50, the incidence is 3% in a white population and up to 5 to 8% in patients of African origin, and this only rises with age. And the point I wanted to make is not all patients with paraproteins or abnormal light chains have myeloma, and in fact, studies have shown that about 19% of patients found to have a new M protein have myeloma, so the majority do not. How do we define MGUS? So it's a M protein under 30 grams per litre with no related organ or tissue involvement. By organ or tissue involvement, we mean no hypercalcemia, no renal impairment, no anemia, no lytic lesions or osteoporosis with compression fractures, and no symptoms of hyperviscosity or recurrent infections. Technically included in the definition is a bone marrow infiltrate less than 10%, but this is something that we consider in clinic rather than in the primary care setting. So MGUS itself is a very variable condition, and there are some patients who don't require follow-up at all for it, and some patients who should be monitored closely. So the way we determine which patient falls into which group is their risk factors. So we know the size of the paraprotein can affect their risk, and an IgG paraprotein over 15 grams or IgA or IgM over 10 grams is associated with an increased risk of development of myeloma. An abnormal serum free light chain ratio also increases your risk, and anyone with a non-IgG paraprotein is high risk. Here we have a table that's taken from the study that published the risk stratification scores for MGUS, and we can see that patients in the low risk category, so they have no abnormal risk factors. So this may be a patient with a small IgG paraprotein of 6 grams, they have a normal serum free light chain ratio. They have a 2% chance or absolute risk of progression to myeloma at 20 years, so it's very low. Conversely, our high-risk patients, those with, say, an IgA paraprotein of 16 grams with an abnormal serum-free light chain ratio, have a 27% absolute risk of progression to myeloma at 20 years. We use this. So low-risk, very elderly patients do not require follow-up for MGUS, as their likelihood of progressing to myeloma is very low within their lifetime. Other low-risk patients, once they're assessed in haematology, can be discharged to primary care with obviously ongoing guidance and help from us as needed, and should have 6 monthly to annual checks. And other patients that continue to be followed up in haematology clinic, normally at least at a 6 monthly basis. Patients that are then found to have a stable paraprotein and that don't have any clinical concerns or evidence of progression can sometimes be discharged to community follow-up. So this was a query that actually came up on Kinesis. It was, what do I need to monitor for a low-risk MGUS patient? And I've put a few options in here. A paraprotein and immunoglobulins with urine Bence-Jones protein, full blood count, UNE, calcium, and if available, serum-free light chains, clinical assessment of the patient, well, this might be a leading question, but D, all of the above and more. So the answer is D, and what I mean by more is that the patient needs to be educated about their condition and the symptoms to look out for, as we're probably only seeing them on 1 or 2 occasions through the year. And if they do develop any symptoms compatible with myeloma or lymphoma, they should be re-referred back to us, as should anyone that has an increase in the M component of more than 25%, or anyone that develops an unexplained anemia, other cytopenia, abnormal renal function, or high calcium. And I've just put here a screenshot from the Myeloma UK website, because they have an excellent section on MGUS, which has both online and downloadable resources for patients and medical professionals. And why is this so important that we keep an eye on the right patients? So it's because unfortunately myeloma is associated or classically late to present and has high complication rates. And this is due for a number of reasons. It is rare. So there is under 6,000 cases diagnosed annually in the UK, and it presents with very common symptoms such as back pain and fatigue. Symptoms can occur late on in the disease, and there is generally a low awareness in the general population about myeloma and what it is. As such, there's a higher risk of complications. And in a study by Howell in 2013, it was looking at reasons why there was less use of the urgent referral pathway for possible myeloma diagnoses than other malignancies. And if we look at the pie chart in the middle, we can see why this is so important. So this pie chart shows the route to haematology for patients with new diagnosis of myeloma. This is taken from Howell's study in 2013. So we can see that a third of patients presented acutely or critically unwell to A&E. Only 11% of patients were referred via a 2-week wait pathway, and 27% of patients came through another GP referral pathway. And above, we can see the reason why this is so important. So if we compare 1-year overall survivals for patients that presented via A&E, it's 51%. Compared to patients coming through a 2-week wait referral pathway, it's 82%. And these findings have been echoed in other studies. So to summarise the graph on the right, this is a graph taken from Larizopoulos' study of the same year that showed a variation in the number of GP consultations prior to referral by cancer type. And it shows odds ratios of 3 or more general practitioner consultations before referral. And as we can see on the right, breast and melanoma, which there's a lot of awareness for, were referred very quickly. However, at the other end of the scale, we have myeloma. And again, the reason for late referrals is probably the complexity of it and the fact it presents with such common symptoms and such rarity. So, who to test? Anyone that you've got a clinical suspicion of an M protein related disorder, or anyone with abnormal tests, and this can include a raised ESR, an unexplained anemia, high calcium, or renal failure, a raised total protein, particularly if one or more of the immunoglobulins is decreased, or as we saw before, a low immunoglobulin unto itself, or an increased urinary protein, and when to refer to us. So all patients with symptoms or physical signs suggesting underlying myeloma or LPD or amyloid. And this can include M proteins, significant Bence-Jones proteinuria, or unexplained abnormal investigations. So we've talked about 2 quite broad topics in quite detail. So for the third section, I was just going to do a quick fire round on cytopenias that will bring us into our quick reference referral guideline that I put together and I'd like to get sent out to you and will hopefully be helpful. So this is a query that's taken from Kinesis about cytopenias, and it's a 33-year-old lady who has recently dropped her neutrophil count. It's always been a bit low, but consistently been below 1 for the past year. Her B12 is normal, her HIV test is negative, and her LFTs and UNEs are okay. Her folate level is low at 2.2. She's on no regular medication. Her ethnic group is described as Other Asian, and she is well in herself. Now, does this warrant any further investigation? So, any neutrophil count below the normal range should be looked into in more detail. And the first thing to ask yourselves is the patient got any clinical signs of sepsis or infection? And if so, they should be sent as an emergency to A&E. If the patient is well, we should consider potential causes. Further investigations can include a blood film, autoimmune screen, viral serology, and haematinics. Always remember to do a medication review and consider benign ethnic neutropenia, and look out for red flags. an abnormal blood film, pancytopenia, lymphadenopathy, or splenomegaly. If there are any red flags or an increased susceptibility to infections, patients should be referred urgently to haematology. For other unexplained persistent neutropenias, we are happy to see them in a routine referral pathway. Lymphopenias. We have a 74-year-old lady who has a background of polymyalgia rheumatica and has recently come off steroids. She had a full blood count because she was feeling tired that showed a normal hemoglobin, white cell count and platelet. The only significant abnormality was she was lymphopenic. Lymphopenia is very common and most often reactive, and one of the most common causes is again medications and particularly steroid treatment. Chemotherapies and radiotherapies can also be associated with lymphopenia. And chronic inflammatory conditions, these can be autoimmune or chronic infections. There are some rarer inherited disorders that cause lymphopenia, such as Wiskott-Aldrich syndrome, and hematological malignancy can be associated, so always just review symptoms and for any other hematological abnormality. And lastly, thrombocytopenias. Now this is another Kinesis query about a patient who's had a full blood count for mechanical back pain and tiredness, and it was noted that her platelets have been low, but only mildly so, for the last few years. But recently they have dropped to 82 and subsequently 68. She's had some reactive lymphocytes on her film. And again, the query is whether this lady needs urgent or routine referral, or whether she could be followed up in the community. So here we have a brief pathway for the evaluation of thrombocytopenias. We should consider and do some information gathering. So over what timescale has a thrombocytopenia occurred? And is there any history of bleeding? What does the rest of the full blood count look like? If reactive lymphocytes are mentioned, has there been any recent viral infection? The differential diagnosis for thrombocytopenia can be broad. Viral infection is up there at the top, along with medications, hematinic deficiency, autoimmune disease, and alcohol. A mild thrombocytopenia is common during pregnancy, but we should always have lymphoproliferative disorder at the back of our mind. Now, patients with a stable platelet count and otherwise normal hemoglobin or white cell count, they can normally be followed up in the community. However, if the patient's count dips below 50, or whether they have a count between 50 to 100 that's associated with other cytopenias, splenomegaly or lymphadenopathy, pregnancy, if they have an upcoming or planned surgery or dental procedure, or have thrombocytopenia associated with one thrombosis, these would be the patients that should be referred to our clinic. So just wanted to do a quick summary of what we have covered today. So we're back to our pie chart of Kinesis queries, and we've spoken about macrocytosis, hematinic deficiencies, and cytopenias, and immunoglobulins. Don't know where that's disappeared on my pie chart. And I just wanted to lead in to here our quick guide to haematology referral to St George's Hospital. So this is a A4 page that I put together that includes all the categories that were found with queries on Kinesis and some more included. And I've been asked by the transfusion team just to highlight this one to you here, and it's our new iron deficiency clinic. So any anemias that are secondary to iron deficiency and patients that are intolerant to oral iron supplementation can be referred to our iron deficiency clinic for consideration of IV iron. Now, all patients should have a full blood count and iron binding studies within 4 weeks of referral. And just as a reminder, this does not replace referral to gynecology or gastroenterology as needed. And the IDA clinic have a separate email, which I've included here, and a telephone number. But I will ask Deanne to distribute the quick reference guideline to you after this presentation. So I'd like to just draw things to a close here and say thank you very much for having me to speak to you today. I hope this has been helpful, and are there any questions or queries?
Well, let me come in here. My name is Matt Klammer. I'm a consultant hematologist. I've been sitting in the background here while Casper's delivering this very nice talk. So thank you very much for that. I've been fielding some questions here throughout the talk. So I summarized a few things that come through. You can see them in the chat box, really mainly referring to MGUS and some rather unspecific things we might find in MGUS or myeloma, such as raised ESR, which is really not very specific and could have a lot of other contributing factors. So I think it's not a very good measure. Earlier on, we had some comments about the value or availability of MMA testing and homocysteine testing. So I responded to that, saying that it's available in South-West London pathology. It's our chemistry colleagues actually who do this, and they may require fresh sample and to look for homocysteine and MMA. But it's worth pursuing in the cases where the diagnosis is otherwise doubtful, as Cass has really wonderfully explained to you. This is just a short summary of the comments I've seen throughout the talk. I'd be interested to see what you feel about the referral guide document. Would you be able to use this in your practice on the GP portal site or something like that? Dear, we don't seem to be able to hear.
I was wondering what was going on there. I'm wondering
if people can respond to this or not.
Hold on one second. Let me just see if I can just unmute people. Hold on one second. I'm just see if I can.
Maybe people
can unmute people if they can.
Maybe raise their hand. Use the raise hand feature in the.
I'm just going to unmute them all.
Yeah. Okay. That's maybe best.
I think you're muted.
Okay. Just give me 1 second, sorry.
Yeah.
Somebody's got their hand up. Okay.
Yeah, I can try to unmute them here. It's Alta.
Here you go.
Hello. Could you explain what to do when TIBC is low and iron level is low and ferritin is normal and FBC is normal? What do you do in that situation?
Who do you want to answer this, myself or Cass? I give Cass the first response. So you have a low total iron binding capacity. You got a normal ferritin and a normal hemoglobin. Was that
Yes.
summarize the case?
Yes, normal FBC, normal ferritin, low TIBC, low serum iron.
Of all the iron binding studies that we do, the serum iron is the one that is of least value, because really it just shows you iron in the circulation at any point in time. The only real value of serum iron is to investigate for possible iron toxicity, like iron overdosing, accidental or in a suicidal intent. Other than that, serum iron is rarely any use. The total iron binding capacity is useful because it actually differentiates between like a saturated iron and a low and an unsaturated iron situation in the body. So in iron deficiency, usually you have a low binding you have a high binding capacity because the transferrin, the shuttle protein, is not saturated. So the capacity to bind iron is high. Whereas in a situation where you have a lot of iron inboard in the body, the saturation of the iron shuttle protein is high. The binding capacity is low. So the binding capacity basically is the inverse of the saturation, if that makes sense. Ferritin is a very useful measure of iron, basically iron stores in the body, unless you have an inflammatory situation in the background in which it stops being so useful. But here, the iron binding capacity helps you to differentiate between iron deficiency and iron repleteness. Often we find a low iron binding capacity in patients who have a lot of iron on board but can't utilize it. So it could be actually high. The iron binding capacity could be low in anemia of chronic disease, which of course is what many of your patients will have. So all these parameters together may actually help you a lot to differentiate between iron deficiency or an anemia of chronic disease. Serum iron is rarely useful.
Okay, thank you. So we don't go so much on the serum iron, go more on the ferritin.
No, forget about it. Just don't even look at it unless you think your patient has an iron overdose or something. It's not useful at all, particularly not on its own. Forget it.
Okay, thank you.
Right. Are there any other questions from any participant? Atta, is
your hand still up? Again up.
Okay. At Centelia, if the folate and B12 are low, they automatically do the better tests. But why don't you do that at St. George's?
Good question. I think these things cost money. Southwest London pathology are really decide on what to do, and the people actually who have this algorithm under their control paradoxically are chemists. What reflex testing occurs is therefore different in Centelia from Southwest London pathology. Centelia at this moment not part of it. They will become part of it soon, and their practice may change. But I think the reflex testing is a complex thing that actually to go to the secondary test probably is only makes sense when you have more clinical details in the background. So I think it would be very useful before doing that to clarify the background of the situation with the referrer, or for the referrer to get in touch with the chemist to discuss it, and it could be easily added on.
It just takes up more of our time to re-request it, to do another blood test and contact the patient.
Potentially, if you don't have if you don't have a recent blood test, it can't be done anyway, because these are all quite time-sensitive assays. They're not easy to do. You probably would need a fresh sample anyway. But before actually requesting, it would be very useful to discuss with the duty chemist about the background and be advised on the utility of the test.
Centelia, they do it automatically, though.
Yeah, to have a fresh. That I think comes down to the judgment of the chemist department, what they do, what we call reflex testing, to do it automatically. I'm aware that St. George's don't do this at the time. Southwest London pathology don't do it, but it's up for discussion.
Thank you.
Any other comments, questions? We're quite interested, actually, as you can imagine, about the referral guide pathway that we put together. Do you any immediate feedback from that? If people, well, you can't see it, maybe Cas can put it back on the screen. Maybe have a look at it. We could make it available to the GP portals if you find that would be helpful. Maybe I give control back to Cas to show you the document.
Right. I'm just gonna. Yeah,
I think
so
we can only see some of it. It's actually only the upper half. Maybe you guys can you scroll down in it?
Oh, I only have it as a screenshot.
Oh, okay. We have this is just a screenshot. So actually, half of the referral things on the bottom of the document, and that actually includes things like lymphadenopathy and like think that would warrant a 2-week referral or not. So it is quite a comprehensive document. I would suggest we put this into the GP forum if there's an appetite for that, and people can see it. Dian, would that be the best thing to do?
Yeah, you can send it through to me, and I can forward it on to the colleagues, the GP colleagues. Yeah,
yes, I think we do that because it's quite a nice one-pager, which gives a lot of detail and a lot of guidance for these common referrals to our clinics. And it clarifies what needs urgent referral, what needs routine referral, and also what investigations can be done in primary care before referral and what considerations. So we covered about 1/3 of these things in the talk today, but there's plenty more. Good. If there's no other questions or contributions from anybody, I think we'll draw the session to a close. I thank Kath for the very nice talk. I enjoyed it. I hope you have as well. And hope to see you again at this forum.
Thank you. Thank you all for attending. I'm in the process of trying to sort out our IT and get the most recent 2 events uploaded. But please, if you can bear with me, Catherine, if I can just, if you can send through that information, that referral, I can send it out to the attendees for
Great.
this event.
Thank
All right. Thank you all. Thank you. Take care. Thanks.
Thank you.
Bye-bye.
Bye-bye. Sounds good. Good. Well, those slides look good.